Inflammatory bowel disease, IBD, is a term for two conditions, Crohn's disease and ulcerative colitis, that are characterized by chronic the inflammation of gastrointestinal GI tract. Ulcerative colitis features limited to the large intestine and the rectum. The inflammation occurs only in the innermost layer of the lining of the intestine. It usually begins in the rectum and lower colon, but may also spread continuously to involve the entire colon. Ulcerative colitis symptoms include, as the lining of the intestine becomes inflamed and ulcerated, it loses its ability to adequately process food and waste or absorb water, resulting in diarrhea, crampy abdominal pain, urgent need to move bowels, sensation of incomplete evacuation, rectal bleeding, anemia if unchecked. The longer the person with ulcerative colitis remains in remission, the less likely the patient is to experience a flare-up of the disease in the following year. Crohn's disease features can affect any part of the GI tract, from the mouth to the anus, but most commonly affects the end of the small intestine, the ileum, where it joins the beginning of the colon. May appear in patches, affecting some areas of the GI tract while leaving other sections completely untouched. The inflammation may extend through the entire thickness of the bowel wall. Crohn's disease symptoms include, as the lining of the intestine becomes inflamed and ulcerated, it loses its ability to adequately process food and waste or absorb water, resulting in diarrhea and abdominal cramps, bloody stools, ulcers formation in the colon and rectum, fever, urgency to have a bowel movement, weight loss, risk factors of IBD, genetic predisposition, immune system disturbance, environmental triggers, smoking, antibiotics, non-steroidal anti-inflammatory drugs, and appendicitis. IBD complications, diarrhea and rectal bleeding, perforated bowel, toxic megacolon, skin and bones. IBD has a significant impact on quality of life. 67% of respondents frequently considered the availability of toilets when planning to attend an event. 60% felt stressed or pressured about taking sick time during IBD. 48% felt that their life was affected by IBD symptoms, even between flare-ups and remission. IBD burden. IBD can significantly affect a patient's quality of life. IBD has emerged in newly industrialized countries. From 1990 to 2017, the prevalence of IBD increased by 85% globally. More than 10 million people are estimated to be living with IBD worldwide. Having a chronic illness such as IBD can be emotionally burdensome, feelings of anger, anxiety, or fear and depression. IBD results in a significant financial burden. IBD is associated with both direct and indirect costs.
Hello, everyone. It's my pleasure to launch the very first event of IBD Academy and this inaugural session of IBD Grand Rounds in collaboration with the IBD Center at Cleveland Clinic. This initiative would not have been possible without the work and dedication of a number of people. I would like to take the opportunity to thank Miguel Riguero, Florian Reeder, and Benjamin Cohen from Cleveland Clinic, the IBD Academy faculty, including Dr. Othman Al-Harbi, who will be presenting tonight, as well as Takeda, especially Ms. Maya Jarkas and Mr. Sharif Ibrahim for their support and sponsorship. And last but not least, Infomed for their first-class administrative secretarial work. So without further ado, I invite our two moderators, Dr. Cohen and Reeder, to take center stage. And our first presentation will be done by our GI fellow, Dr. Dima Malak. Thank you.
Thank you, Professor Sharara, and we're really excited to be here at this inaugural Grand Rounds and excited to go through the cases. So we have two exciting cases today. The first case is going to be ulcerative colitis case, and the second a Crohn's disease case. And my colleague, Dr. Reeder, and I will alternate moderating these two cases with the expert panel we have today. So we will start with the ulcerative colitis case, and Dr. Malak, I think you can go ahead and present.
Thank you, Doctor. So we have a 65-year-old male patient with long-standing ulcerative pancolitis for over 20 years. This patient had recurrent flares managed with steroids. His most recent flare was 3 months prior to presentation, where he was hospitalized and treated with steroids with limited response. CT scan done at that time showed colonic thickening, mainly in the left colon, with subcentimetric lymphadenopathy. Colonoscopy showed pancolitis with endoscopic Mayo score of 3, multiple pseudopolyps, and biopsies were negative for cancer and dysplasia. This patient presented to our center for the first time in March 22. His partial Mayo score at that time was more than 7, indicating severe disease, while he was on 30 milligrams of prednisone. Patient had weight loss and fatigue. He was anemic. He has a high CRP of 62 and a low albumin of 3. Stool studies for C. diff were taken and were negative. Patient was started on vedolizumab and had a good response. He was reassessed at week 24 in a clinic visit. At that time, he was off steroids, had no rectal bleeding. His stool consistency improved, but he still had 7 bowel movements per day with some nocturnal bowel movements. Partial Mayo score during this clinic visit decreased to 4. He had some weight gain. Calprotectin was high, and again, stool studies for C. diff were taken again and were negative. CRP, as you can see in this graph, initially declined after induction, followed by a plateau, and then had a small rise at his last clinic visit. So questions for the audience are the following. What would the best management be in such a patient? Would you consider augmenting vedolizumab or switching therapy? And in case of vedolizumab intensification, would you consider only shortening therapeutic interval from 8 weeks to 4 weeks and then reassess in 3 to 6 months? Or is there a role for therapeutic drug monitoring? And would those intensification help in augmenting response and eventually reaching remission? The second question is, concerning the treatment plan, should we base our decision based on non-invasive biomarkers, which in this case were really high, or should this be an endoscopy-guided decision? And now I will pass it on to the moderators to run the clinical discussion, and then I will be back with you to show the best evidence on those questions.
Well, thanks so much. I think this is this is a very common scenario we encounter in clinical practice. We have just to recap very briefly, a 65-year-old gentleman with very long-standing ulcerative colitis who's had steroid requirements in the past and is now symptomatic and was started on vedolizumab and seems to have had a partial clinical response, but still with elevated biomarkers. And the question is, what do we do at this point? So we're fortunate to have an expert panel among us. So maybe I'll start with Dr. Al-Harbi first and see, when you have a patient, this scenario, they've been started on vedolizumab, how do you monitor response to treatment? What are the time points at which you will assess, and how will you assess?
Okay, so this is actually an excellent case. We see it always in our clinical practice. And what we should do, we should usually do, I'm sure you're doing the same in your centers, where we go with the STRIDE guidelines, where we put the short term, the intermediate terms, and the long terms goals for us, for our patients. So we reassess the patients. Usually the first assessment for our patients will be 4 to 6 weeks. We want to make sure they are clinically improving. There is an improvement in their bowel movement, in the blood. We want to see a little bit of decrease in their inflammatory markers. And also we want to see a decrease in their calprotectin or at least partial response for the medications. After that, usually at week 12, this is the times where we do for them the calprotectin, reassess them again, and to see if there is complete resolutions of the symptoms. We use a lot of the non-invasive markers in our practice to see the response in case, but till now in my practice, I don't really change the management or intensify the treatment only in the non-invasive markers. So maybe for the second questions, in the case there, I usually, once I find high calprotectin, the CRP was still high, and the patient's bowel movement still he's going 7, even there was some improvement, I don't jump the disease or change it before doing an endoscopy. And doing an endoscopy, at that times, we want to make sure that what we are dealing with is a non-resolving ulcerative colitis. We want also to rule out if there is any complications, if there is any secondary infection, especially CMV infection with these patients. This will give us the chance to take biopsy from them. Then after that, we'll decide what to do with this patients.
And I think you've covered it all. We can just end the discussion there. So we were talking about vedolizumab in this case, but does your timing of when you make the assessment change based on the therapy that's used? Like, for example, if you had an anti-TNF, would it be different? Or if you're using a anti-IL-12/23, for example?
Sure. I mean, one of the things that we know about vedolizumab, usually it's a little bit slower actions. Even that's when we see some of the publications, they seem to respond in the next 4 weeks. But when we use other agents, especially the newer agents with the oral JAK inhibitors, we usually assess the response closer than vedolizumab. In my practice, I think usually vedolizumab lag a little bit behind the oral JAK and the anti-TNF therapy.
Great. And so maybe we can get some other thoughts here, see if there's any differences in how you may manage a patient like this. So Dr. Khatoubi, are you on the line?
I was just texting Nancy, so the other folks are not on, so I think we are the panel. Okay.
Well then, Dr. Reeder, maybe we can see other differences in how we may approach things in the U.S. From what we heard from Dr. Al-Harbi.
Yes, I in principle I agree with Dr. Al-Harbi's short, mid, and long-term goals. One critical point that I felt when going through the case is to rule out CMV, because C. diff was negative, and the patient really only had a partial response. So having this information is critical, and I want to separate 2 things with CMV, which is the CMV peripheral markers that we really disregard in the case of a flare like this. We focus on local infection in the gut with biopsies, and then we also count the amount of CMVs in the biopsies or the copy number in the PCR, because CMV can be an innocent bystander. But in general, in severe cases, so Mayo 3, extensive colitis, patient is in the hospital, if we find CMV in sufficient numbers, we usually co-treat, and first with an IV preparation and then oral. So I think that would be important in this case. In general, the situation that is described is not straightforward, which is probably why you brought up this case, which I think is a really good case. To answer one of the questions about drug monitoring, so for vedolizumab, I personally do not use any drug monitoring. What we say PK-PD relationship, so in other words, the drug levels and relationship to how much inflammation is in the gut for vedolizumab as well as ustekinumab, likely as well as risankizumab, is not like for anti-TNFs, where you can make a claim that the level makes a difference. And then the second reason why I don't order these tests is because antibody formation with vedolizumab is very rare. And if you find antibodies, they may not even neutralize. So in other words, if you find antibodies, it may not matter. And if you dose by level, it may not make a difference. So what do I do in clinical practice? If I want to optimize vedolizumab, I would just decrease the interval to every 4 weeks without measuring levels in antibody. In this case, I would see it a bit different in that it looks like a primary partial response. So it's not that the patient had responded before and there's a secondary loss of response. And to Ben's earlier question, how long do you wait in a patient on vedolizumab? And I'm actually quite comfortable waiting beyond 12 weeks, over to 16 weeks, potentially 20, 24 weeks, because there are late responders. But once at 12 weeks with a fecal calprotectin of greater than 1,000, I watch them very closely and have a low threshold and to switch mechanism of action rather than extensively optimizing vedolizumab, because the initial response was not great.
In that case, Dr. Ritter, would you do the scope before switching them to make that decision, or are you comfortable doing that on the ongoing clinical symptoms and elevated biomarkers alone?
Yeah, that's also a good question. You'll find probably heterogeneity in practice to this question. So 2 points to make there. To use biomarkers like fecal calprotectin, you need to first ensure that they correlate with endoscopic disease activity in this particular patient, which in this case, we established that because we have an endoscopy and a fecal calprotectin at the same time. The correlation between endoscopic activity and fecal calprotectin and ulcerative colitis is better than in Crohn's disease, particularly small bowel Crohn's disease, where it becomes even more important to ensure that if there's active disease, is the fecal calprotectin actually high? So where I use the fecal calprotectin, just like Professor Al-Harbi prescribed, it's an early indicator at like 3 months. Which direction does this patient trend towards? But before I switch therapy, I want to get an endoscopy. And I don't, in a case like this, I don't need a full endoscopy. Actually, a flexible sigmoidoscopy would be sufficient for me because it's a systemic therapy. And I expect that if I get to the distal end of the colon, where an ulcerative colitis disease is most severe, if I don't see much difference, I don't need to see the rest of the colon.
I think I agree completely. The one point I would make for the audience is that there are new guidelines, at least in the US, that have been published this past month on the role of biomarkers in ulcerative colitis in particular. And the one situation where, in most scenarios, the biomarker is a trigger for endoscopy. The one situation where the guidelines do say that you could forego the endoscopy is patients with severe symptoms and elevated biomarkers. That's pretty clear of what's going on. You don't necessarily need to wait for the endoscopy to make a decision. I think it also depends on factors like, in your particular center, how quickly can you get an endoscopy? If you have 2-3 months wait time for a scope, then it may be a situation where you don't want the patient symptomatic for that period of time. So you have to really think about what the specific clinical scenario is for the patient and what the stakes are potentially with the treatment modification that you're going to make. It looks like we have some.
Go ahead.
Can I ask a question? I know the CMV issue always comes up when you have somebody who's not doing well or is flaring on biologic. But in your experience, have you seen invasive CMV in patients on vedolizumab monotherapy? Because I cannot imagine that this happens, in this setting. Let's say somebody who's not on steroids, not previously anti-TNF experienced, malnourished, in hospital, in and out of hospital. I would find that pretty unlikely, right?
Yeah,
Yes.
I think that's a pretty rare scenario. And we can get the thoughts of some of the other panel on that. I mean, my experience with CMV, where I would worry most about CMV is if you had a patient that had a sudden change. So maybe they initially responded to the treatment and then all of a sudden things became worse. And what's the reason for that? If it's this patient in particular had a partial response, it's not that there was then a clear worsening after they had the partial response. So I'd be less concerned about CMV, though clearly if they got hospitalized, there would be a role for checking that. But I don't know that I would let that hold up a treatment modification or change in this particular case. But I'm curious, maybe Dr. Khatoubi, what your thoughts are with respect to checking for CMV and the risk in a vedolizumab patient.
Yes, thank you so much. Again, I don't know whether you hear me well. Sorry, the first time you asked the question, I had no access to the meeting. Anytime we have a relapse, of course, we have to ask the questions why. Now, is it infectious, C. diff? CMV comes in the pictures. Again, in our area, I don't see it so frequently. So I totally agree with you. It's on the, we should look for it. We do a flex-sig, take biopsies and see. But frankly speaking, we don't see it very frequently. I like what you said that, unless there's a sudden severe change, then, we can look into this. But, again, it is on the table. It is one of the options we have to investigate.
Yeah, I agree. It's an interesting question in general. It's true that on vedolizumab monotherapy, I don't recall CMV as often as on TNF, and particularly in patients on steroids. In this case, to Dr. Cohen's point, there was a rapid worsening to prior when the patient was on 5-ASA and intermittent steroids and hospitalized. And at least in the United States, in these instances, the incidence of CMV is actually quite robust. If a patient comes in on steroids, hospitalized, you find it in 15 to 20% of cases in a scenario like this.
Now, in terms of, we heard a little bit from Dr. Reeder about his approach with regards to therapeutic drug monitoring. And I think that's a common approach in the United States with regards to the non-TNF inhibitor biologics. But I'm curious maybe what you all are doing in the Middle East. So Dr. Al-Harbi, are you routinely checking vedolizumab trough levels to make decisions about dose optimization or switching therapy?
So for the drug level, actually, other than the anti-TNF therapy, we don't usually use that in our practice, similar to what's happening, I think, in your practice. So mainly it's an infliximab, and some of the centers, they do it for the adalimumab to check the level, to adjust the dose or shortening the intervals, or sometimes to add the immunomodulators with the anti-TNF to try to increase the level and decrease the antibodies. But for the interleukins, the anti-interleukins, like secukinumab and vedolizumab, actually we don't measure the levels here to adjust the dose. But in our centers, actually we're doing similar what Dr. Ryder mentioned there. We usually will shorten the intervals before we switch to another mechanisms, just to try maybe more of a using each biological therapy we have for our patients maximum before giving up in our therapy, especially with the times when we don't have enough biological therapy to cover all of our patients.
Can I ask?
In the interest of time, can we just do the part about the rest of the presentation and then get back to this will allow more discussion, I think.
Yep, absolutely.
Okay, so concerning the first question on vedolizumab augmentation, you can see from the systemic review and meta-analysis that the pooled incidence rate of loss of response to vedolizumab per 100% year follow-up among patients with UC was 39.8. There was low heterogeneity among the cohorts, and the majority of patients had been previously treated with anti-TNF. The mechanism of loss of response to vedolizumab is still not clear. Unlike anti-TNF, immunogenicity is low, and we learned that the alpha-4 beta-7 receptors will saturate at the dosage of 300 milligram every 8 weeks. So in the same meta-analysis, 4 studies reported data regarding the efficacy of vedolizumab intensification. And among secondary non-responders, more than half benefited from dose intensification and recaptured response at the pooled efficacy rate of 53.8%. Now, multiple newer studies were published after this meta-analysis demonstrating efficacy of vedolizumab intensification. Few are still in abstract form, and we have summarized some of those studies in this table. I would like to note that there was heterogeneity among the study population. They looked at patients with secondary loss of response, non-responders, and also partial responders. But despite this heterogeneity, most of the studies showed that dose intensification led to recapture of response and even remission in a good percentage of patients, ranging from 20% to almost 50%. Most studies did not include therapeutic drug monitoring, suggesting that this strategy is not required in the case of vedolizumab. There is only one study, which is the first study, that highlighted the correlation between increased trough level and improved response. Now, this correlation between higher vedolizumab trough level and improved long-term outcome was also reported in many studies in the literature, as in this meta-analysis I'm showing here. However, we can clearly see that there is an absence of a unified cutoff for vedolizumab trough level, and this can be secondary to so many factors, mainly the disagreement between the assays used, and still till now we don't have a standardized or commercially available assay in practice. The variation according to the treatment target, whether we're considering the clinical, endoscopic, or biochemical response, and the phase of therapy, whether we're looking at the induction phase or at the maintenance phase. Plus, it is still unclear whether subtherapeutic vedolizumab concentration is a consequence of a rapid drug clearance or the cause of an inadequate response. Now, concerning the second question, whether treatment decision should be based solely on non-invasive biomarkers or it should be endoscopy guided, I will refer to this recently published AGA guideline where one of our moderators, Dr. Benjamin Cohen, was a co-author. Well, the guideline emphasized at first that combining patient symptoms and biomarkers predicted active intestinal inflammation and enables optimization of treatment. But the most important thing to look at when we are considering biomarkers is the pretest probability for moderate to severe endoscopic inflammation, because it is at high pretest probability those biomarkers, they become most accurate. Now, to be able to know the pretest probability for moderate to severe symptoms, usually we have to refer to those scores, the stool frequency score and the rectal bleeding score, and patients have to have high scores of 2 and above. Now, to help apply this in practice, this algorithm was proposed by the AGA. So for any patient with symptomatically active ulcerative colitis, it is important at first to distinguish between mild symptoms and patients with moderate to severe symptoms. So for patients with mild symptoms, such as the case of our patient, whether biomarkers were elevated or normal, in both cases, the guidelines suggest endoscopic assessment rather than empirical treatment adjustment. Now, in the patients who have moderate to severe symptoms, if the biomarkers were elevated, here the guidelines suggest the treatment adjustment and avoiding endoscopic assessment. While in patients with moderate to severe symptoms, but normal biomarkers, which means when you have a discrepancy between the symptoms and the biomarkers, the guidelines suggest endoscopic assessment rather than empiric treatment adjustment. Now back to our patient. This patient, we performed the colonoscopy. The colonoscopy showed normal colonic mucosa with multiple pseudopolyps increasingly larger in size in the left column. Random colonic biopsies were taken. And we can see clearly that we have ulcerative colitis with mucosal healing Mayo 0 and multiple pseudopolyps. These are some of the figures taken from the colonoscopy. We can see pseudopolyps with superficial inflammatory exudates interspread with normal mucosa. Now for the pathology, there was no acute inflammation and the Nancy index score was 0. So hence we have a histoendoscopic healing and multiple pseudopolyps. So for the next time remaining, I will try to quickly address the following questions. I will go over the performance characteristic of fecal calprotectin and how it can be misleading. And I will answer if there's an association between pseudopolyps and elevated fecal calprotectin, and if pseudopolyps are predisposing factors for neoplasia, and should their presence necessitate shortening surveillance interval. Now, concerning fecal calprotectin, as we all know, they can be elevated due to many causes, including infection, celiac disease, and SAIDS. This makes them misleading, but particularly in patients with ulcerative colitis and those who have intermediate pretest probability, meaning those with mild symptoms, like the case of our patient, you can see that there is a high false positive rate at different cutoffs. In this case, fecal calprotectin is considered to have very serious imprecision and inconsistency, and this was highlighted in the AGA guideline. Now, are pseudopolyps associated with elevated fecal calprotectin? Well, this retrospective study from Spain that aimed to analyze possible false positive results of fecal calprotectin in ulcerative colitis patients owing to the presence of inflammatory polyps, we can see that out of 39 UC patients reviewed, 12% had high fecal calprotectin and colonoscopy immediately after, showing no macroscopic nor histological activity. All of those patients had inflammatory polyps, and however, they were completely clinically asymptomatic. We can see in the table that the fecal calprotectin was measured twice and in both times showed very high values, reaching thousands of micrograms per gram. Pseudopolyps, a risk for neoplasia. Well, data from previous case control studies showed that pseudopolyps are considered predictive factors associated with colorectal cancer with an odds ratio of 2.5. However, the limitation of these previous case control studies is that they did not account for the burden of the underlying inflammation, and there was also selection bias by comparing colorectal cancer patients with low-risk controls. There were studies like the study I'm showing here in the slide that actually looked at the segmental inflammation and at the level of the endoscopy and histologic level. And you can see in the diagram on the right how they calculated the cumulative inflammatory burden. And also in this study, they showed an association between an increased cumulative inflammatory burden and the risk of colorectal neoplasia, as is proven in this Kaplan-Meier plot on the right. Now, when we looked at the multivariate analysis, the cumulative inflammatory burden was the most important predictor for colorectal neoplasia. On the other hand, the post-inflammatory polyps had no association with the risk of colorectal neoplasia. Another study showed similar results. This was a retrospective study of 2 cohorts from USA and Holland, and over a median follow-up of 4.8 years, there was no significant difference in the rate of colorectal neoplasia occurrence between patients with and those without pseudopolyps. So despite that they are not considered predictors of colorectal neoplasia, patients with post-inflammatory polyps are still classified at intermediate risk of colorectal cancer by most guidelines, and the recommendation is still to aim for shorter surveillance interval of 3 years in those patients. Now back to our patient. 4 months after his colonoscopy, our patient was doing better. We kept him actually on the same treatment, and his partial Mayo score decreased to 1. He normalized his CRP. Patient also gained weight. The calprotectin was still very high, but this is likely attributed to the pseudopolyps. Finally, as per the guidelines, patient was scheduled for colonoscopy and biopsy in 3 years.
that was a fantastic presentation. I think really does highlight some of the key, pitfalls also of biomarkers. And so, if I was going to summarize this and put this together, I would say, as Dr. Reeder had mentioned in some of his comments earlier, it's important that when you start therapy, you benchmark biomarkers against the disease activity to know which potential biomarkers you can monitor over time. So in my practice, I will check both the C-reactive protein and the calprotectin when I know the patient has disease activity, and then I will follow the selective biomarkers through the treatment course to assess response if they were elevated at the start of therapy. But you have to keep in mind that there are things that can cause elevations in biomarkers besides disease activity. Pseudopolyps are certainly one of the main things, and this is why it's still important to do that initial assessment, looking at endoscopic response after you start a therapy. And those, what I highlighted before about the guidelines, I think are important, is that if you have very severe symptoms, of course, which this patient did not, they had a partial response to symptoms, that's the situation where you could consider bypassing the endoscopy, but that the guidelines leave room for still doing the endoscopic assessment, based on patient interest and physician interest as well. So before we turn it over for the Crohn's disease case, maybe Dr. Sharar, do you have any closing comments about the?
No, I think this was a very interesting case, and in basically putting a holistic approach to the patient, is that the biomarkers, without the symptoms, without the history of the patient, without the endoscopic assessment, sometimes you don't get the right picture. And I think it's important, this patient continued to have 6 or 7 BMs a day, but in somebody with a non-elastic colon after 20, 25 years of disease, that's probably the normal type of bowel movement that this patient has. So I think putting that in context and thinking about the patients, not only in terms of one blood test or one stool test, then just have to look holistically at the whole thing and make that decision.
Excellent.
Yeah, that's an excellent point. And in fact, the concept that ulcerative colitis is a progressive disease is emerging. Then are groups forming, defining exactly what you mentioned, Professor Sharara, on how does a normal look like in a patient with 20 to 25 years of ulcerative colitis with a fibrotic, a stiffened colon. And then one other point in the presentation was excellent, I think, is the drug level data that was shown is all association. So these are not patients where the drug levels were adjusted or monitored based on a certain clinical occurrence. And this has a lot of limitations because the drug levels are linked to disease activity in the gut. So if you have very severe disease activities, your levels will be lower. And if you have less active disease, your levels will be higher. And hence you have the association of higher levels with better disease, but really it's not the antibody level that does it.
The chicken and the egg story.
Exactly. And I think one needs to be very careful in interpreting it.
And before we go to the last case, there was one online question, so want to give a chance to address that. And I can tell that this question came from the United States, because the question is, do you tend to use the vedolizumab levels to increase the odds of insurance approval for optimizing treatment? I'm going to imagine that's not something that you're dealing with as much as we are. And I mean, practically speaking, not usually. If for some reason a patient was denied a dose escalation, then yes, maybe I would check a drug level to provide additional support. But in general, with vedolizumab, where you only have one move, which is to increase the frequency, if I think that there's disease activity and I'm going to make a modification, I just do it without the drug level.
Yeah, I agree with that completely.
May I add one comment, please?
Yes. Mm-hmm.
So I don't know whether it is right or wrong, but what I do usually after patients failing anti-TNF, I start right away every 4 weeks on Vida. Do you do that?
I personally don't, and I'm not aware of any data that has tested the every 8 weeks versus every 4 weeks in TNF failures. In general, anti-TNF failures, vedolizumab is not the strongest drug, and this network meta-analysis suggests that using, for instance, a JAK inhibitor may be a better choice. But I've not done that. Ben or Professor Sharara or Professor Al-Harbi, have you used that approach?
Not from the get-go, no.
When we had no other options, but to stop video, we knew that it is not so effective. That's why I go every 4. Some patients did well, others did not. And actually, I agree totally. It's not the best options to stop video after anti-TNF anyway. Thank you so much.
You should consider reporting your experience if you have done it in several patients. I'm not aware that there's any data on it.
The initial labeling from Uric did allow you to do early dose escalation if you didn't see a response in the induction period, but I agree. I don't generally go to an every 4-week dosing straight off.
Thank you.
But perhaps we move on to the second case, and let me thank Professor Sharara and Professor Al-Harbi for bringing us all together. And IBD is global, and it makes me very happy to discuss cases across continents and across nationalities. I would like to hand it over to Professor Al-Harbi for presenting the second case. And my name is Florian Rieder. So Dr. Cohen and myself, we lead the IBD section at the Cleveland Clinic together. We're very happy about the partnership. So Professor Al-Harbi, it's all yours.
Okay, thank you for being with us. Today we have a case of Crohn's disease and the long-term complications of anti-TNF. I have here with me Dr. Hussam Al-Murad. He's one of our F3 GI fellow. Will present the case. Dr. Hussam.
Thank you. Thank you, Dr. Osman. So this is a 27-year-old gentleman diagnosed with ileochronic fistulizing Crohn's disease, perianal, also a perianal disease involvement in 2010. So he was treated previously with steroids. He had no previous bowel resection. He first came to our center in 2011. At that time, he was having perianal disease, some diarrhea and abdominal pain. His endoscopy showed at that time ulceration at ileocecal valve and at terminal ileum. So at that time, in 2011, patient was started on infliximab and Imuran. Later on in 2012, regarding his perianal disease, his fistulas, it improved. However, he was having loose bowel motion, abdominal pain. We repeated his endoscopy at that time. Few ulcers at terminal ileum and ileocecal valve were noticed. At that time, his infliximab level was 4 and his infliximab antibody was negative. So at that time, as he was having a flare and not well controlled, we increased his infliximab doses to 10 milligram per kg, and we continued on Imuran. And clinically, patient was improving, just mild symptoms he was having on and off during his clinic visit, but no active flare that occurred at that time. So since from 2013 till 2016, as I said, his infliximab level were fluctuating between 5 and 7, and his antibody were negative at that time. Till 2017, he was readmitted at that time with flare, abdominal pain, and diarrhea. His colonoscopy showed erythema and deep ulceration involving the whole colon. Also, some aphthous ulcers at the terminal ileum and ileocecal valve. Also, his MRI showed disease activity at that time. So he was treated with prednisolone, and we continued on infliximab. In 2018, a patient was admitted at that time with weight loss, fever, and night sweat. We did for him a CT abdomen, which showed multiple enlarged intra-abdominal lymph nodes. And biopsy from this lymph node, unfortunately, came as Hodgkin lymphoma. So he was diagnosed with stage 2A Hodgkin lymphoma. Infliximab and azathioprine was on hold till we reassess him back after chemotherapy. And he received 6 cycles of chemotherapy, and he reached remission from lymphoma after 8 months. After he reached remission after 8 months, we assessed him back in the GI clinic. Unfortunately, he was having symptoms, diarrhea and abdominal pain, and his inflammatory markers were elevated. His CT abdomen also showed the activity of the disease, thickening and mucosal hyperenhancement in the colon, in the hepatic flexure, and terminal ileum thickening. Also, his colonoscopy showed severe ulceration involving the whole colon and the terminal ileum. So at this point, what is the next step for this patient? So shall we resume his azathioprine and infliximab, start adalimumab, start vedolizumab, or go with ustekinumab? So I will try to answer this question later in the topic review that I will give. So at that time, we started him on istiquinumab.
Sorry,
Yes.
Dr. Masad, should we stop here and have a quick discussion and then we continue after? Would that be okay?
Sure.
Perfect. So then I would ask the panel to come on. And a very interesting case. So in a patient with an unexpected turn, so ileocolonic Crohn's disease with perianal disease, started on infliximab and azathioprine, and then on a CT scan finding enlarged lymph nodes, turns out to be Hodgkin lymphoma that's being treated. And while the patient was treated, the biologic therapy was stopped. I want to start a discussion because I wanted to ask Professor Sharara, what are your considerations in a patient with perianal disease? What is your first line therapy? And then when do you use combination versus monotherapy?
Thank you. I mean, very nice case, of course. Normally, when you have fistulizing disease and perianal disease, I think the best treatment usually is an anti-TNF. I think there's only level 1 evidence for infliximab and level 1B or 2 evidence for adalimumab and post-hoc analysis. So essentially anti-TNF. My general strategy is to use combination therapy with infliximab. I don't usually use combination therapy with adalimumab, except in one situation, somebody who has previously failed infliximab with the development of antibodies, because then the chance of a development of antibodies is pretty high. We've actually done a meta-analysis on the adalimumab combination therapy and published that in IBD journal. And really, there's no evidence that the addition of, or at least let's say based on the evidence there's no clear-cut evidence that it does add much. I mean, only in the Diamond trial was there a slightly better response early on with the combination therapy. But nevertheless, if I do use combination, I try to basically, with adalimumab, I try to basically remove it at the soonest possibility to remove. The question that I had, maybe sending it back to the panel, do you check for, this is a young person, you check EBV antibodies before, and is that the kind of patient that you never use thiopurines in if they're antibody negative? I mean, this patient had Hodgkin's lymphoma, which is actually probably not directly related, but who knows?
Dr. Cohen, what is your practice?
I do not check. I mean, in the United States, the overwhelming majority of patients we see have had some exposure to EBV. I think there's been various cost analyses about, the utility of checking. I have some former colleagues of mine that do check it, but my personal practice is not to.
Yeah, I agree. And at that age in the United States, the exposure is in the mid 90s to high 90s to EBV, and I personally don't check. But I wanted to ask Professor Al-Harbi, so you start on combination therapy. When do you use azathioprine? When do you use methotrexate? And then what dose of azathioprine do you start the patient on when you use combination?
In our centers here, we usually use mainly azathioprine more than methotrexate because of non-availability of the methotrexate sub-Q. We only have the oral, and we find our patients that cannot really tolerate the orals. When I first came back from my training, I tried to use a high dose of azathioprine with 2.5 milligram per kg. What I find in our populations, with this dose, actually they go in neutropenia. I will end up with severe infections. So usually I try to keep them between 1.5 to 2 milligram. And majority of my patients will be around 100, because I don't thought that our patient tolerates a higher dose of azathioprine comparing to what's being written in the usual guideline textbook.
So I agree with this approach. There is data showing that half dose azathioprine may be enough to prevent antibody formation, but in case of perianal disease, I do use the full dose. In the United States, we test the azathioprine, the genotype for risk of the leukopenia, what you mentioned. you do that ahead of starting, but otherwise we would also start full dose. I have one quick question for Dr. Cohen before I have Professor Sharara answer the question in the case after chemotherapy. So Dr. Cohen, you worked a lot with drug levels, and it's commonplace to start combination therapy with anti-TNFs, but why don't we just induce the patient and run by drug level is one question. And then the other one is, when do you use combination therapy with, for instance, ustekinumab in perianal disease, or do you do that at all?
Both very good questions. I think right now we don't have, it is a common approach, and I will admit that in my clinical practice that I will do an optimized monotherapy with infliximab only if I'm not going to use combination therapy for whatever reason. If patient is at a higher risk, for infection, if they have particular concerns about being on combination therapy, but there's not prospective randomized data to support that approach. There is a clinical trial ongoing in the United States called the Optimized trial, where patients are being randomized to a optimized monotherapy approach using a clinical dashboard. And there's been various centers, including the Leuven Center and some in the US, looking at dashboard-based dosing of infliximab and how you can use trough drug levels, albumin, CRP, other parameters about the patient to predict future drug levels at current dosing to adjust in that way. So the study is randomizing patient to using the dashboard-based dosing versus usual care, which may include combination therapy. So I do think we need to prove the principle, because there's a lot of debate about therapeutic drug monitoring in general, particularly proactive drug monitoring, where this would fall. But hopefully we'll get some of that data. Now, to answer the second question, which was, I forget your second question.
Do you use combination therapy with?
Oh yeah, ustekinumab, right? I don't. I mean, I think the one scenario where I would consider, if somebody has like very debilitating disease, had failed multiple prior therapies, and now we're putting them on ustekinumab, I probably would do it, but no evidence to support that.
Yeah, so I agree with you. So the data points towards no extra benefit with immunomodulators in combination therapy. But what you do is exactly what I do in patients that have very complex perianal disease, have failed multiple biologics. I go all in to see an effect, even though the data does currently not support it. So I didn't want to steal Dr. Hussam's thunder, but Professor Sharara, quick question, quick answer. So the questions were on the slide. Patient underwent chemotherapy. The Hodgkin lymphoma is in remission. What's your next step? You're comfortable going back to anti-TNF, or you choose a different option?
No. So, I mean, I wouldn't use a drug that has pretty significant immunosuppressive properties or in a systemic way. I think a more targeted therapy would be my choice. Clearly, the evidence, we don't have really long-term evidence on this, but it stands to reason that a drug such as vedolizumab would be safe in that regards. Ustekinumab, also, there's no noise regarding, intestinal or even extra intestinal cancer. So I think any of those two options would be reasonable, with, of course, a discussion done with the patient about the fact that, potentially cancer is potentially can come back.
Okay, yeah, I agree. I would probably choose ustekinumab in that instance as the next choice, given that it's Crohn's disease. But both are options. I agree with you. I've not forgotten about Dr. Kotubi, who we will call on after the next stop, and I give it back to Dr. Hussam.
Okay. Also, his imaging showed significant interval improvement, and his colonoscopy showed just small erosions and skip erythema compared to the previous severe ulceration that he was having. So we brought up this case to discuss both. Is it safe to use azathioprine and anti-TNF in Epstein-Barr negative patient? And how could we manage Crohn's disease patient post malignancy? So I think we already.
So I don't know if our moderators want to comment on these things and to add any things regarding the ABV negative patients. I know in the States, majority of the patients are ABV negative, but in our community, actually a good percentage of our patients are ABV negative.
Okay.
So should we do the test, and on those patients, how we could really manage the azathioprine and the combination therapy in these patients?
Okay, very good. Let me ask Dr. Hussain real quick. Is that the end of the case, or is there more?
This is the end of the case.
End of case. Okay. So then let me call on Dr. Kotubi. How do you handle these EBV negative, potentially EBV negative patients in your practice? Do you test all of your young patients for EBV?
Well, as Dr. Benjamin mentioned, actually we don't check the EBV for these patients, and we only do the TPMT before we start the azathioprine. And actually, I had another question, just on the same page. Would you, because we've been hearing, do you prefer using methotrexate in males rather than using azathioprine?
Mm-hmm.
So I really love to hear your opinion on that.
So I'm going to ask Dr. Cohen to answer this.
In young males, I will consider the use of methotrexate due to the concerns around hepatosplenic T-cell lymphoma. But the other thing we encounter in the US, a lot of these patients go to college around, if we're dealing with like a teenager, let's say, or a young adult, and there's heavy alcohol use potentially. So that impacts utilization of methotrexate in some of the younger population that we see. If I had a high degree of EBV negativity in our patient population, I may check it. What I would say is that my general practice with the combination therapy is to use it for 6 to 12 months and then stop it. So if we're talking about long-term lymphoma risk, it's really around extended combination therapy. What I will do is use the combo at the start, give them the best, put my best foot forward, see if I can get a response, and then optimize the drug levels and stop the thiopurine. So that really does minimize most of the lymphoma risk we're going to encounter. Now, if somebody develops acute EBV on therapy, that's a dangerous situation, obviously.
I have to admit that I try to avoid azathioprine as much as possible these days because the emerging data suggests the increased risk of malignancy. Then if you have a potentially high percentage of ABV negative patients, that may aggravate that, and all the other side effects of leukopenia, infection risk, skin cancer, and so on. I try to avoid it. But obviously methotrexate in young females is a concern regarding pregnancy, potential pregnancy complications, and in young males, what Dr. Cohen described regarding alcohol use. In general, hepatosplenic T-cell lymphoma gets constantly brought front and center for combination therapy, azathioprine and INT'L in young males, but the actual incidence rate is exceptionally low. So it's a very, very rare tumor, and I feel comfortable even with azathioprine combination therapy in young males because I think the benefit outweighs the risks. Before we hand it over to close with Dr. Hussain, Professor Al-Sharara, any other pearls about managing Crohn's disease patients post-malignancy?
Well, it depends on the type of malignancy, of course. Solid organ tumors, lymphomas, basal cell carcinoma of the skin. It depends on the type of cancer. There are some cancers where basically I think the risk remains high, melanoma and so on. So, and I think the lowest amount of immunosuppression is key, and also definitely a close, vigilant assessment of the patient for cancer risk at multiple levels, the whole body assessment. So generally speaking, yes, the disease has to be, moderately severe enough to make us go back and consider systemic treatment. And then when that happens, then this is what needs to be done. Of course, I think JAK inhibitors for Crohn's are going also to come onto the stage, and those would be contraindicated, I would assume, in this particular setting.
likely this will be the recommendation when they come. So post-cancer, perhaps not the best drug. Dr. Hussan,
Yes.
I hand it back to you for the best
Yes.
available evidence.
Thank you. So regarding IBD and malignancies, this is the accepted manuscript that will be published in the ECO guidelines. So they mentioned that the solid organ tumors and hematological malignancies are more common in IBD patients compared to the general population. And they mentioned that it's not clear, is it due to the disease itself, the chronic inflammation that's going on, or due to the medication that we are giving to the patient? And they provided this table regarding IBD therapy and risk of malignancy. They mentioned that thioprin is associated with lymphoproliferative malignancies, non-melanoma skin cancer, cervical cancer, while TNF antagonist is associated with lymphoma and melanoma. TNF antagonist with thioprin combination therapy is associated with lymphoma and more than either alone. Vedolizumab and istiqimumab are not associated with malignancy, and this is why we go with the istiqimumab in our case. JAK2 inhibitors can cause all except non-melanoma skin cancer, and methotrexate is associated with non-melanoma skin cancer. Regarding thioprin and Epstein-Barr virus, they advised that before starting the therapy in young adult male patients younger than 35 years old, to check the EBV status, and if they are naive, which is the negative for IgG, Epstein-Barr, to consider other medication than thioprin. Regarding the effect of malignancy treatment on IBD, they mentioned that hormonal therapy has limited evidence to cause a flare, while radiation and chemotherapy doesn't cause flare. Actually, they said that chemotherapy has a protective role, cytotoxic effect, that will protect against IBD flare. And checkpoint inhibitors is also associated with higher rate of IBD flare. This is another paper published in the BMG regarding managing IBD in patients with previous history of cancer. So they mentioned these factors to be considered when taking the decision in this kind of patient. So to assess the IBD factors, which are the factors to assess the risk of flare in the patient, so evidence of disease activity, how severe it is, the age of the patient, what kind of medication he received before, and the cancer factors to assess the risk of recurrence of the malignancy. So the cancer type, the stage, time since diagnosis. Also, it should be taken into account that the patient factors, so the patient preference, patient comorbidities also should be taken in the decision. And they suggested this algorithm in dealing with patients with IBD and previous history of malignancy. So they first asked to assess the IBD activity. If it is not active, to assess the risk of IBD relapse. So if the patient is at low risk of IBD relapse, to go with standard monitoring. And if patient has high risk of IBD relapse, to go with enhanced, more frequent monitoring for the patient. And if the patient is already in active status, IBD flare, if it is mild, you can go with steroid, with mesalazine, with exclusive enteral nutrition. If the patient is having a moderate to severe disease activity, they suggest to have a multidisciplinary decision with the oncologist. So if the patient is high risk for cancer recurrence, you can go with steroids and exclusive internal nutrition. If patient has acceptable cancer risk or low risk, you can go with biological medication such as anti-TNF and Vedo and ustekinumab. Thank you.
Yeah, thank you very much. Excellent presentation. I think the cases both were really nice. Before I give it back to Professor Sharara for closing the session, I wanted to ask one audience question and then also thank the panel. So one audience question is, what do you think the cause of lymphoma is in this case? In this question I will direct to Dr. Professor Al-Harbi. What do you think the cause of lymphoma is in this case? Medication-induced or IBD itself has the risk?
So as Dr. Hussan mentioned in the review, it's difficult to really judge in these cases if it's the cause of the disease itself, if it's the medication or the combination of the two things. So I think it's a multifactorial and for our patients, the cause of the lymphoma.
Mm-hmm. And based on probability, probably neither of the two may actually be the case. And then the second most common probably would be azathioprine, and then potential association with IBD. But Hodgkin's lymphoma and IBD association, I'm not aware of this having been described, but it is a quite common cancer in young patients. So it may just be not related to either of them. So thank you so much for the panel, Professor Sharara, Al-Harbi, Kotubi, Cohen, and I give it back to Professor Sharara for closing. And thanks for the case presenters, really good cases.
I want to again thank everybody for taking the time to attend. Hopefully this is the first of many events. And hopefully, I'm sure we'll have more attendance with time as the reputation of the quality of such an event starts to spread. I want to again thank Flo and Ben for being with us and providing the valuable input, and thank the presenters as well as the other members of the panel, and of course all the people who have attended who we have not had the chance to actually see their names. Hopefully we'll see you again on June 7th for the next IBD Grand Rounds.
Thank you.
All right.
Thank you so much.
Bye. Bye.
Unique gut selectivity of Entyvio contributes to the favorable benefit-risk profile observed. Entyvio is an integrin antagonist that binds to the alpha-4 beta-7 integrin, which is expressed specifically by a subset of gastrointestinal homing T lymphocytes. Entyvio is superior to adalimumab with respect to achievement of clinical remission and endoscopic improvement in patients with moderately to severely active ulcerative colitis. 383 patients were assigned to receive intravenous infusions of 300 milligrams of Entyvio versus 386 patients were assigned to receive subcutaneous injections of 40 milligrams of adalimumab. The primary outcome was clinical remission at week 52, defined as total score of less than or equal to 2 on the Mayo Scale, no subscore higher than 1 on any of the 4 Mayo Scale components. Varsity study results. At week 52, clinical remission in overall population. Entyvio provides 40% more likely clinical remission than adalimumab in the overall primary endpoint. At week 52, clinical remission at anti-TNF naive population. Entyvio provides 40% more likely clinical remission than adalimumab in anti-TNF naive population. Endoscopic improvement at week 52, overall population. Anti-TNF naive population. 42% higher endoscopic improvement in patients in the Entyvio group than in the adalimumab group. Entyvio achieved clinical response as early as week 2 and surpassed adalimumab in week 6. Entyvio is superior to adalimumab in achieving absence of active histolic disease at week 52 in ulcerative colitis, based on GBO score and Robarts Index.